Your slides are visible, but it's not in show mode, Nakar.
So now has it
Yeah,
become
now it's perfect. Yeah, perfect.
Okay.
Oh, one more slide. Yeah, super. Good.
Okay.
You just go back. You can keep the slides there because we are not going to show anything in the upfront there. So you can keep the show mode.
Sure. Okay.
Now it's not in show mode. Again, it went back to the old. Yeah, perfect. So the plan, Dr. Arvind, now we'll start the sessions in another couple of minutes there. I think Dr. ICP Dean might join sometimes. I need to check whether he's joined or not. If he's joined, Sarah will introduce some couple of words there. Then we can start the presentations. You can plan 35-40 minutes there. So whatever questions happening in the side, we can answer at the end of your presentations. And finally, some posters questions I just put for the people, whether they got the points or not. This is a basic idea, and we'll wind up by 8:30 sharp. Mostly postgraduates and DNB residents, and some of the general practitioners also joined.
Okay.
One more minute to go. Okay, good evening. Good evening, one and all. We are bringing another sessions of infectious diseases short certificate program today. Today, we are last 3-4 weeks, we are discussing about syndromic specific modules. Initial first couple of weeks, we talked about the general modules. Now we move to the next 4 weeks of the syndromic approach we are going on. In the syndromic approach, we so far finished skin and soft tissue, urinary tract infections, and pneumonia modules. This week, we are talking about CNS infections. For the sessions today, the speaker is Dr. R. Arvind. He is an associate professor and head of the Department of Common Medical College, Trivandrum, and is a well-known speaker and is the authority for CNS infections. He has seen a lot of rare and emerging infections, recent outbreaks, for example, Nipah, as well as primary hemiplegic meningoencephalitis, rare types of meningoencephalitis, and rare types of CNS infections also. In his practice, he has seen and has got a lot of publications pertaining to this field, and is one of the well-known speaker from India, as well as one of the key speakers member, we can call it. So today, he's going to discuss about CNS infections. The same mode we are doing it, the 30 to 40 minutes of presentations, followed by 10 minutes of Q&A, and finally on post-test questions, presentations can happen for 5 to 7 minutes. So this is a plan today. Without further ado, I'll ask Dr. Arvind to start his sessions. The session is open to you, Dr. Arvind.
Excuse me. Good evening, everyone. I'd like to thank Suresh sir for this opportunity. So next 30 to 40 minutes, I will touch upon how to approach the CNS infections, basically a pragmatic approach to CNS infections. So basically, when you talk about CNS infections, the entire spectrum of or a gamut of CNS infections will comprise of the meningitic syndrome, the encephalitic syndrome, meningoencephalitis, brain abscess, myelitis, encephalomyelitis, and subdural empyema, of which the commonest will be, say, meningitis, which is the inflammation of the meninges, encephalitis, that is the inflammation of the brain parenchyma, a combination of both, that is meningoencephalitis, brain abscess, inflammation of the spinal cord, that is myelitis, and inflammation of brain parenchyma as well as myelitis together, and as a complication, subdural empyema. So basically, I will be touching upon how to approach based on the symptomatology all these CNS syndromes. So just like in any infectious disease, when a patient is presenting with features of infection, so basically we need to have an algorithmic approach. Obviously, the most important thing, even in CNS infections, will be taking a very good clinical history as well as examination, looking at the epidemiological clues and things like that. And knowing the comorbidity profile, whether the patient is immunocompetent or immunocompromised, and if it is immunocompromised, where it is a B cell deficiency, T cell deficiency, extent of immunosuppression, all these things are very important so that now we can have an idea about the predictable microbiology. And regarding the clinical syndrome, the previous slide we discussed that a patient could have a meningitic presentation or encephalitic presentation of meningoencephalitis like that. So based on the history, we need to have an understanding of which part of the neuroaxis the patient's problem is, whether it is a meningitis or whether it is a meningoencephalitis, things like that. And based on the clinical history, based on the epidemiological parameters, the anthropology, and the immunosuppression or immunocompetence comorbidity profile, we should have an understanding about what we are supposed to cover through our empirical treatment. That is, we need to have an idea about the predictable microbiology. And then suppose you are dealing with a nosocomial pathogen, probably knowledge about the local resistance rates also will help you. And since the CNS, blood-brain barrier is there, and it's an angenically privileged site, so optimizing the PK/PD as well as the toxicodynamics of the antimicrobials that you're using to treat the infection also is very, very important. So basically, this is something that all of us are very familiar with. That is antimicrobial stewardship, where we need to start the right drug at the right time, right dose for the right patient. Here, the most important aspect will be like in meningitis, the golden hour is once you are suspecting a patient as having a possible or probable bacterial meningitis, the right antibiotic has to be started within say 1 hour. So this 1 hour time frame is very important because ideally you're supposed to do a CSF study, and so you need to draw the blood culture. At least two sets of blood culture has to be drawn in suspected bacterial meningitis. So despite all these things, the antibiotic has to be started within say 1 hour of suspecting meningitis. So this is the most important aspect as far as the right timing is considered. Sir, uh, Suresh Kumar, sir.
Yes, go ahead, Arvind.
Sir, I think so. I will stop the share, and because the PPT there is a slight issue, I will share the other PPT,
Yeah,
sir.
take your time there and do it. Meantime, I'll ask the participants, you start
Sure, sure, sir.
putting your questions there. When Dr. Arvind is working on the slides, you just start putting your questions so that we can start the discussions also a little early. You take your time, Dr. Arvind. Put it in show mode.
Yes, sir.
Yes, good.
Okay, sorry for the technical glitch. So I will start from here. So basically, we talked about the importance of starting the antibiotic within, say, 1 hour of diagnosis of or suspecting a bacterial meningitis. And most important aspect as far as the suspected bacterial meningitis is considered is that we need to take the the sample for a lumbar puncture as well as blood culture has to be drawn. And if that is not possible within 1 hour, so we should not wait and we should actually load the patient with antibiotics. So it is in this context that in April this year 2025, WHO came with a consensus statement on a guideline on how to treat bacterial meningitis, how to diagnose and treat bacterial meningitis. And one major recommendation there is that in all patients, a CSF study is this thing, CT, brain imaging is not required prior to a lumbar puncture. So there are indications, specified indications for doing a lumbar puncture, like suppose the Glasgow Coma scale is less than 10, if the patient is having a focal neurological deficit, patient is having a cranial nerve palsy, an adult with seizures or localizing signs. So these or a heavily immunocompromised patient. So these are the indications for doing a cranial imaging prior to lumbar puncture. So the most important aspect as far as the recent WHO guidelines is concerned is that so if the patient do not have any of this criteria, you can straight away proceed with lumbar puncture as well as drawing blood culture, and within 1 hour you are supposed to start the patient on antibiotics. And when we are looking at the etiology of a bacterial meningitis, basically age specific there are the common etiologies are like that more than 1 month to adolescence, you need to look for, say, pneumococcus or meningococcus, then non-typhoidal salmonella, then as well as H influenza. So since H influenza is part of the vaccination, H influenza is actually being replaced. In adults, we need to cover for, say, pneumococcus as well as meningococcus. And in patients who are having a qualitative T cell or a quantitative T cell defect, like in elderly patients, in pregnant ladies, post-transplant patients, those on, say, immunosuppressants, etc., we need to cover for a listeria as well. So this is the importance of knowing the predictable bacteriology as far as a bacterial meningitis is concerned. And once you are sending the blood culture as well as the CSF study, you can empirically start the patient on ceftriaxone or cefotaxime, and
అన్న
usually we
ఏసీ
are
ఆన్ చేయి
preferring
వేడిగా ఉంది
ceftriaxone to
Please all mute
cefotaxime.
yourself there. The speaker is presenting. Please mute yourselves.
So we will prefer ceftriaxone to cefotaxime to cover pneumococcus as well as meningococcus, and that is how we approach. And if there are risk factors where we should be suspecting listerial meningitis, we will be adding ampicillin and amoxicillin. And when should you add vancomycin? Vancomycin should be considered in setting where you are actually expecting high MICs to penicillin or ceftriaxone. So in such situations, you will go with ceftriaxone or vancomycin. Interestingly, based on the gram stain itself, you will have an idea about the stewardship, like if it is a gram positive cocci or gram negative diplococci or say gram positive bacilli. Based on that, you can have an assessment of whether it is a pneumococcus, meningococcus, or say listeria or say gram negative pathogens. And regarding the treatment duration also is very important. So once you start on this ceftriaxone with or without vancomycin, or say ceftriaxone with amoxicillin or ampicillin for coverage of listeria, the duration of treatment is also very important. So if the culture is coming as positive, or if you are using a PCR, nucleic acid based diagnosis, and if you are actually pinpointing on the diagnosis, if the patient is actually clinically stable in meningococcal meningitis, actually around 5 to 7 days of antibiotics. WHO now recommends around 5 days of antibiotics. And for H influenza and Staph aureus, it is around, say, and pneumococcus, it's around 10 days of antibiotics. But for listeria and say gram-negative meningitis, it will be around 21 days of antibiotics. But most often in many of the centers, we won't be having any etiology despite the culture or the say nucleic acid-based test, etc. Sometimes because of prior antibiotic use, etc. So we may not be able to pinpoint on the diagnosis. So in such setting, the current recommendation is that the patient is clinically stable. So the sensorium is normal, patient is febrile, and there are no features or complications. And if that status is remaining for 48 hours, 7 days of antibiotics will be enough. So that is the current recommendation. So when we are actually looking at the when we are looking at the molecular methods, the current WHO guidelines clearly mention that these molecular methods, or the pathogen identified through this monoplex PCRs or multiplex PCRs, that should be actually interpreted in the context of your history, the clinical examination, the epidemiology, and your the culture as well as the AST. So basically, you need to have an idea about the pretest probability, and just based on that, that you have to look at the PCR. So even in this molecular era, WHO clearly states that the gold standard happens to be your culture as well as the AST, and that is actually very very important, especially with regard to pneumococcus and all, where looking having the penicillin MIC makes a lot of difference. So it's based on the MIC that you select whether you can go ahead with penicillin or ceftriaxone. So now coming to one common syndrome, the CNS syndrome, that is encephalitis as meningoencephalitis. Here we should be aware of the diagnostic criteria for encephalitis. This is actually from the 2013 International uh, Encephalitis Consortium. So basically, encephalitis has to satisfy major criteria as well as two or more of the minor criteria. So in a patient with features of, say, fever, and if they are presenting with altered mental status, which is defined as a decrease of level of consciousness, lethargy, or a personality change which is lasting for 24 hours or more, with no alternate cause. So this is the major criteria. So that means that the brain parenchyma is involved. Now we need to see whether it is an infectious cause or not. So the minor criteria will be documented fever of more than 38 degrees Celsius within 72 hours before or after presentation. This is very important. So patient might present with altered sensorium, and fever can come, say, later on. So that can also satisfy the criteria to be to be satisfying with encephalitis. Then presence of generalized or partial seizures, new onset of focal neurological findings, CSFW pleocytosis, then neuroimaging abnormalities suggestive of encephalitis, or abnormalities in the EEG. So major criteria plus three or more minor criteria will make it a probable or confirmed encephalitis, and two or more criteria will make it a possible encephalitis. So one thing that all of you should be aware of is the differentiation between encephalopathy and encephalitis. I'm not going to spend much time on this. So basically, presence of fever and headache, it is more in favor of encephalitis. And then the presence of seizures, neurological signs, etc., it is more in favor of encephalitis. And seizures in encephalopathy is more generalized. If you're having focal seizures, it's more in favor of encephalitis. CSF pleocytosis, EEG showing focal abnormalities, MRI showing focal abnormalities, etc., also will favor encephalitis. Now, looking at the etiology. So, in encephalitis, the majority of the etiologies are viral. And, the commonest cause of sporadic encephalitis, as per literature, happens to be herpes. And herpes, if not diagnosed early and start on acyclovir early, the outcome is going to be very detrimental. That is why, whenever a patient is presenting with fever and altered sensorium, so the gut feeling is to think of HSV and to start acyclovir. So HSV is not the commonest cause of encephalitis in India, but still it remains as a treatable cause of encephalitis. And if not treated early, if acyclovir is not treated early, so that when the window of opportunity is lost, patients can have mortality as well as severe morbidity. So we should be aware of HSV1 as well as HSV2 as causes of encephalitis. The other herpes viruses like varicella, CME, Epstein-Barr, HHV6 also can lead to encephalitis. And CME, Epstein-Barr virus are important, especially in the immunocompromised category. Influenza A as a cause of encephalopathy or encephalitis is actually underreported. The major reason is that if you are looking for CSF influenza, PCR is likely to be negative. So any patient who is presenting with influenza-like illness, that is fever, cough, sore throat, etc., later on developing altered sensorium, think about influenza also as a possibility. And if you want to confirm the diagnosis, you need to send a nasopharyngeal swab as well. So that is why, NIV insists that, if you don't have a diagnosis for an encephalitis, along with the CSF sample, you need to send a nasopharyngeal or the oropharyngeal sample, a serum sample, as well as the urine sample. Then we all know that especially in children and all, enterovirus, poliovirus is a cause of encephalitis, and the clue is going to be the seasonality as well as the presence of rash. In enterovirus encephalitis also, if the CSF is negative, a stool swab for PCR also might help. Then measles, mumps, and rubella can also lead to encephalitis. And mumps meningitis is one cause of meningitis where you can have a neutrophilic pleocytosis, especially in viral meningitis or encephalitis. We are expecting lymphocytic pleocytosis. The exception happens to be the mumps where you can have a neutrophilic pleocytosis. Rabies is a is a very common cause of meningoencephalitis, especially encephalitis in this part of the world. And in any patients who are presenting with phobic spasms, you should also be aware of that rabies can present as dumb rabies as well. So proactively, please do ask for history of any mammalian bites or the licks, etc. So that is very important. But unfortunately, a diagnosis of rabies, whether it is a furious rabies or a dumb rabies, we don't have effective antivirals effective against rabies. Then arboviral encephalitis is also something that we need to be very much aware of, especially Japanese encephalitis, which is supposed to be the commonest cause of encephalitis in India, as well as West Nile encephalitis. West Nile encephalitis, the clue will be like in JE, Japanese encephalitis, since there is a propensity or tropism towards the basal ganglia, the patients can present with extrapyramidal features. And West Nile, the anti-onsal is affected. And any patient who is presenting with flaccid paralysis with features of encephalitis, we need to think about West Nile encephalitis. And JE, West Nile, and dengue, since all of them are flaviviruses, there is likely to be an antigenic cross reactivity. So basically, if you want to diagnose JE, West Nile, etc., so we need to look at plaque reduction neutralization assay. Now, these are the non-viral cause of encephalitis. Now, I'm not going to spend much time on mycobacteria, etc., because that is a huge topic. But we need to understand that tuberculosis can present as subacute or chronic meningitis. It can also present as meningoencephalitis or encephalomyelitis, and all sorts of CNS syndromes can occur with mycobacteria. Now, for the last 4 to 5 months, we have been having an outbreak of mycoplasma. So, respiratory infection with encephalitis, please do think about mycoplasma encephalitis as well. Listeria, especially in patients who are at risk of developing listeria, can present as meningitis as well as encephalitis. Rickettsia, especially the strep typhus, is very common here. Is also a very common cause of meningoencephalitis. Leptospirosis in areas where it is endemic can present as meningitis as well as meningoencephalitis. Brucellosis in patients with epidemiological link can present as encephalitis and meningoencephalitis, or sometimes as myelitis as well. Salmonella typhi, you all know, and Burkholderia pseudomyeli, especially in areas where we are having a lot of cases of melioidosis, like South India and all. This melioidosis usually present as multiple abscesses in hepatosplenic area, etc. But it can also present as encephalitis. Then rare causes like the Whipple's disease and syphilis is making a huge comeback, and we need to understand that any patient with cognitive decline, etc., neurosyphilis should be also be considered, because it's a treatable cause of encephalitis. To this, we should consider HIV as well. HIV is a viral cause of encephalitis. And then in patients who are immunocompromised, we need to look at the fungal etiologies, the parasitic etiologies, cerebral malaria, which can occur in anyone, toxoplasmosis, and any patients who have exposure to the fresh water, we need to consider amoebic meningoencephalitis, which can present as primary amoebic encephalitis, meningoencephalitis, which is due to Naegleria, which is having a very acute course. That is, the exposure to water will be within 7 days. Incubation period is very low, very short, and it will be a fulminant course. That is primary amoebic meningoencephalitis due to Naegleria, and granulomatous amoebic meningoencephalitis can occur due to it is a close lead of tuberculosis, can occur due to acanthamoeba, Balamithia, sapenia, etc. So granulomatous amoebic meningoencephalitis will present like have a subacute or a chronic sort of presentation. So most important aspect is that we have been seeing a lot of cases of amoebic meningoencephalitis over the last 2 to 3 years in India, and there are a lot of publications showing that even the CDC documents show that we need not have a direct exposure to water. Like, usually we take it as a person has bathed in a pond or something like that. The person with meningitis, we need to think about amoebic meningoencephalitis. Someone with drowning presenting with features of meningitis or meningoencephalitis, we need to think about amoebic. But, if you're looking at the literature available, so any sort of contact with water, like from a sprinkler, etc. A lot of patients report from India do not have a direct link to the pond water, etc. So our take will be that what CDC says that any patient with pyogenic meningitis who is not responding to treatment. Pyogenic meningitis means there's a neutrophilic predominant with hypoglycorrhea, not responding to the usual treatment, we need to a fresh sample, wet mount, ask the inform the microbiology lab and check for the trophocytes. So that's very, very important. From our experience, I will say that if you don't have a cause for meningitis or meningoencephalitis, definitely alert the microbiology lab and get them to look for trophocytes because it's a treatable cause of meningitis and meningoencephalitis. Now, I'll take you through one case, a 30-year-old gentleman with history of fever, myalgia, headache of 9 days duration, altered sensorium, gait attacks, and GTCS of 2 days duration. So basically, fever, myalgia, headache, now we can say that patient is having a meningitic syndrome, and now the altered sensorium is there along with GTCS. So there is a parenchymal involvement as well. So basically, patient is having a acute meningoencephalitic syndrome. On examination, he is having a maculopapular rash as well as cervical and axillary nodes. And this is the neuroimaging pattern. It is showing, evidence of the flare hyperintensities are there. So basically, it is a meningoencephalitis, acute onset meningoencephalitis, and the clue is rash as well as the presence of nodes. So based on the neuroimaging patterns for meningitis as well as for especially for the encephalitis, you can have some idea about the microbiology involved or the pathogen. So basically, any patient with meningoencephalitis, please do discuss with your neuroradiologist or radiologist to get clues so that you can ask for specific panels to diagnose your pathogen. For example, an HSV encephalitis has a propensity towards medial temporal lobe as well as orbitofrontal lobe. JE, as discussed previously, has a propensity towards the basal ganglia substantia nigra thalami. Varicella propensity towards cerebellitis, multifocal cortical anomalies, vasculitic-like presentation. So Nipah is a problem in Kerala as well as in areas neighboring Bangladesh. There, what we find is focal subcortical deep white matter and gray matter lesions. Adam also can occur as a complication of any infection. Vaginal, you can have a deep gray matter, brainstem white matter lesions. And Chandipura has been a problem last year in Maharashtra where you can have a normal MRI pattern. So this is also very, very important. Dengue, you can have involvement, symmetrical involvement of basal ganglia, thalamus, something which we refer to as the double donut sign. Influenza can affect the cerebellum as well as the corpus callosum. So basically, by having a discussion with your neuroradiologist, you can have an idea about the pathogen which is involved. For example, this is the classical herpes encephalitis. You can see the hyperintensities in the orbitofrontal as well as the medial temporal lobes. JE has a propensity towards the basal ganglia, so dengue, thalami, etc. So neuroimaging has scored some sort of a discriminative value in selecting which panel or which pathogen needs to be ruled out. So coming back to this case, the CS of the profile, you can say there is a lymphocytosis and there is no hypoglycorrhea. So the staining was okay, the culture was sterile, and viral PCR, the multiplex panel was also negative. And we need to understand that many centers in autoimmune meningitis and autoimmune encephalitis basically, autoimmune encephalitis is now emerging as one of the commonest cause of encephalitis, even surpassing the viral cause of encephalitis. Autoimmune encephalitis is becoming one of the commonest cause of encephalitis. And when should you suspect this autoimmune encephalitis? Basically the patient will act weird, and the patient will be having a lot of dyskinesia as well as autoimmune abnormalities, and MRI might appear to be normal. It is in these situations, especially when there is an autoimmune balance, autonomic fluctuations, etc. Autonomic fluctuations, we need to think about autoimmune encephalitis. Now, coming back to the patient, he had rash, nodes, and you can see the scar. So this is a case of scrub encephalitis. And scrub encephalitis, this is one study, largest study on AES done in India by the NIMHANS team. They followed up around 10,000 cases of AES. And interestingly, since it was done in a research mode, they were able to establish the diagnosis in around 49.2% of the patients. This is actually very high by Indian standards. So globally also, around only 30% of the cases are having a diagnosis. Around 70% of the patients are not having a diagnosis when they present with acute encephalitic syndrome. Since, in this study, they were using a research mode, they used a lot of molecular methods. They were able to identify the cause of encephalitis in around 49%. And JE happened to be the most common, it's 16%. And 16% of patients also had scrub typhus. So basically, scrub typhus encephalitis is an underrecognized entity, and this is something that we need to understand because scrub typhus is something which can be easily be treated. And another interesting aspect of the top three pathogen, the third top pathogen happened to be the dengue encephalitis. So basically, JE, scrub, and dengue happen to be the commonest cause of encephalitis as per the study done by Nimhan's team. And when we are looking at our data, that is Trivandrum Medical College data, this is interesting because in 2018-19, we had around 158 cases of encephalitis. Obviously, the commonest happened to be, we could identify the etiology only in around, say, 25% of the cases. And obviously, the commonest happened to be influenza associated encephalitis. So this is because, when here, when we are sending the CSF sample, if the patient is having a respiratory symptoms, either a pneumonia-like presentation or ALI-like presentation, we are sending the nasopharyngeal swab as well, and we are able to pick up influenza. So it could be an encephalopathy or encephalitis. And this is one publication from our pediatric hospital in 2019 showing that influenza encephalitis in around 18 patients, and the mortality was also around 18.5%. So what I'm trying to convey is that if patient is presenting with or influenza-like illness and developing seizures, altered sensorium, so along with the CSF, please do send the nasopharyngeal swab for influenza PCR as well. Now, coming to specific entities, the differentials you need to entertain. So this is a 21-year-old who returned from Middle East, and he had features of fever, hemorrhagic rash, myocarditis, acute kidney injury, hepatitis, DIC with encephalitis. You can see the hemorrhagic rash and blood in the right tube, and is in a comatose state. You can see the hemorrhagic rash and all. Since he had come back from this thing, initially he was diagnosed with varicella elsewhere, but when he reached our hospital, we were not able to find any vesicle. We could see only the hemorrhagic lesions like this, petechial lesions and all. So these were the differentials that we entertained for this case of encephalitis. Hemorrhagic varicella, expanded dengue syndrome, Crimean Congo hemorrhagic fever, because he is coming back from Middle East, an area where CCHF is quite common. Then Ebola, Marburg, etc. Hemorrhagic fever with encephalitis, even though it has not been reported in Middle East, we also need to keep this in mind. Rickettsiosis is always possible. Meningococcemia, since the patient is having petechial rash or Lassa fever, all those things. So basically, if you don't have a diagnosis when dealing with a patient with encephalitis, hemorrhagic rash, etc., the patient has to be in isolation, and you have to take all the protective methods. Better be safe than be sorry, sort of thing. And this patient's PCR turned out to be varicella. It was hemorrhagic varicella with encephalitis. Okay. But the important thing is that we need to keep all other DDs in mind so that we can take the adequate IPC measures. That is also a very important part of treatment of any encephalitis. Another situation where the epidemiology is very important. So this is a 9-year-old girl presenting with fever of 1 week duration. And towards the end of the second week, she is developing seizures. And she had, say, leukocytosis, thrombocytopenia, transaminitis, ARDS, myocarditis, and encephalitis. So the clinical diagnosis of an expanded dengue syndrome was made because the clinical profile was suggestive of dengue in the first week, but towards the end of the second week, she presented with an encephalitic syndrome. And interestingly, there was, she was living in an area where, the monkeys, wild hogs, etc., do visit. And these were the differentials entertained: the expanded dengue syndrome, viral encephalitic syndrome, strep typhus, and KFD. So, even attention to the last diagnosis, Casimir forest disease, especially in the Shimoga area. From Shimoga in Karnataka, now it has expanded to that entire stretch of the Nilgiris. So, any patient who is presenting with, say, dengue-like presentation in the first week and towards the end of the second week, if they are presenting with encephalitis, please do consider the possibility of Casimir forest disease as well. And this is why the epidemiology is very, very important. We need to know the epidemiology. In Maharashtra area, Chandipura virus is also common. So based on the local epidemiology, we need to decide on what investigation to send, because KFD, etc., it is not there in your multiplex PCR or the monoplex PCR panel. So you need to make a clinical diagnosis of KFD, and you need to ask for the specific ELISA, things like that. You need to discuss with your microbiology team. Now coming to an immunocompromised situation, that is, that in any patient post-transplant, there is a timeline for infections. That is what happens in first month, what happens from 1 to 6 months, and after 6 months, etc. And this is referred to as Rubinstein. So I'm taking you through a 16-year-old boy, 2-year post-renal transplant, who presented with fever, myalgia, headache, and transient maculopapular rash over the trunk. On day 5 of symptom onset, he developed generalized seizures, alteration of sensorium, and asymmetric flaccid paresis. A clinical diagnosis of an encephalitic syndrome with anterior onset involvement was made. So basically, a post-transplant patient presenting with an encephalitic syndrome with anterior onset involvement. So, the CSF film array, there is a multiplex PCR panel which actually looks at the common etiologies of encephalitis. It was negative. So what is optimal investigation to be sought in this case? So basically, we are dealing with a post-transplant patient who is presenting with an encephalitic syndrome with anterior onset involvement. So we have discussed that anterior onset involvement with flaccid cautery paresis is classical about enteroviral infection as well as West So here we need to think about West as well. In West what is the the investigation to be done? The most important thing that we should know is that in Japanese encephalitis as well as West so the CS of viremia is usually very transient. So by the time the patient develops seizures or develop encephalitis like presentation, the viremia won't be there. So you need to diagnose JE or West based on the IgM in the serum as well as the CSF. So here the diagnosis should be based on CSF as well as West IgM and CSF or the JE IgM. Here we are thinking about West Okay. So basically, if the serum IgM is positive and the CSF IgM is positive, we'll take it as a case of West Nile virus infection. Suppose in this case, the dengue and the JE IgM are also positive, then the problem is that there is always a chance of a flaviviral cross reactivity. And we need to look at investigations like plate reduction neutralization test to confirm whether it is West Nile or JE. Here it is easy because the flaccid cautery paresis is usually a feature of West Nile. And the take-home point from this slide is that for JE and West Nile, you should not be looking at the CSF PCR. Instead, you should be looking at the CSF and serum IgM. Now, there are certain etiologies that, without knowing the epidemiology, is very difficult to suspect and, diagnose. So it's a case of an unfortunate boy who returned from Dubai with an abscess, inguinal abscess and a lesion in the scrotum, and he developed the encephalitis and was admitted, and on day so 5 hospitalization he died. So all the microbiological and the molecular CSF panels sought from that hospital turned out to be a negative. And since the patient is from Middle East, they thought about neurobrucellosis, and since there was an inguinal abscess, etc., they thought about melioidosis and tuberculous meningoencephalitis, etc. But this was a case of monkeypox with encephalitis. Only case of only person who had died in India due to monkeypox. So there was confusion like this patient had just 2 lesions, one inguinal abscess and one scrotal lesion. So as per the criteria, this is enough for any patient who is returning from Middle East, which is hyperendemic area for mpox. Any patient within 21 days returning with any rash or an abscess or oral ulcer or rectal ulcer like thing, you need to rule out mpox. So this was a case of mpox encephalitis. So in this scenario, patient had just 2 lesions. With just 2 lesions, someone developing encephalitis and dying is not very common in mpox. So we thought about the possibility of mpox triggering an autoimmune encephalitis like MOGAD. This is also something that we need to keep in mind. Now, coming to the investigation aspect, should we have a syndromic approach, or should we have a multiplex PCR sort of approach? Multiplex PCR means, all of you might be working in hospitals, which might be having access to the BioFire or the other multiplex PCR panels where, you're asking for the encephalitis or meningoencephalitis panel, and, within, say, 1 to 2 hours, you're getting the PCR for 17 pathogens like that. So the sequential approach means that you are having a based on the clinical features, etc. Say the patient is presenting with meningoencephalitis and your MRI is showing say a lesion in the medial temporal lobe. So you want to rule out HSV, and you are just asking for a monoplex panel. That is actually sequential approach. You're ruling out HSV, and then you're asking if HSV is negative. You're asking for other etiology sort of thing. So what should be ideal? So that depends on what is available to you. You can select either monoplex panels or some multiplex panels. So, basically this was a gentleman who came to one of the hospitals in Kerala in 2023 with features of fever, myalgia, headache of 5 days duration. And then he developed a viral bronchopneumonia like present with dyspnea. And basically fever, myalgia, headache, and on day 5 he presented with dyspnea. So a professional diagnosis of a severe acute respiratory infection, bronchopneumonia was made. And since the ABG was suggested of ARDS, he was mechanically intubated and mechanically ventilated. So what is ideal treatment strategy here? So it is in 2023, start oseltamivir immediately and send for SARS-CoV-2 and influenza PCR. Start oseltamivir and send for multiplex PCR respiratory panel. start subtracts on doxy, oseltamivir, and send for panel, the respiratory panel as well as tropical fever PCR panel. So all these answers are sort of acceptable because here the syndrome appears to be like a viral bronchopneumonia or a community acquired bacterial pneumonia with ARDS sort of thing. So all these things might be acceptable, like starting oseltamivir or subtracts or doxy plus oseltamivir and sending for all the panels. But uh, so this is the basic advantage of going for a syndromic testing, means that if you are going for a syndromic panel like a respiratory panel or a encephalitic panel, so basically you can diagnose the pathogens earlier and you can go for IPC measures or like stewardship and optimizing the treatment, etc. is quite possible. But in this case, you will be surprised if I say that this was how the Nipah in 2023 presented. So this is basically the problem. So in Nipah endemic areas, you can have two sources of presentation for Nipah. You can have an encephalitis with an ARDS sort of presentation, or sometimes you can have an encephalitis like presentation alone. And sometimes, as in this case, patient can present with ARDS, and once intubated, we don't know whether the patient has gone into encephalitis sort of thing. So in Nipah endemic area, any patient who is presenting with ARDS or say encephalitis, our IPC has to be spot on because there is always a possibility that patient can turn out to be a super spreader, especially in ARDS sort of presentation. The chance of spread is very high. So the IPC has to be spot on, especially in Nipah endemic areas like the districts where Nipah has been reported in Kerala as well as the border area of Bengal, Nadia and Siliguri, etc. Now coming to the certain diagnostic hints that will help us in pinpointing the diagnosis of meningitis or meningoencephalitis, etc. In endemic areas, those who are presenting with fever, conjunctival congestion, myalgia, jaundice, acute kidney injury, high-risk job, calf and muscle tenderness, we need to have leptospirosis as one of the differential diagnosis. Fever with rash, toxic look, no response to usual antibiotic. We need to look for eschar, which might be present in around 25% cases of strep typhus. And strep typhus is, as we have discussed, a common cause of uh, encephalitis. Influenza like illness or an ILA cluster in the family or locality plus seizures. We need to think about influenza associated encephalitis or mycoplasma encephalitis. Encephalitis plus hemolysis plus ILI. Need to think about mycoplasma. Fever, rash, polyarthritis, seizures. Chikungunya is a well-known cause of encephalitis, especially during the outbreak season. Zika also, just like chikungunya, can present with fever, rash, and polyarthritis and can present as encephalitis. Fever, rash, and seizures. So, any patient with encephalitis with rash, we need to think about enteroviral infections, dengue, chikungunya, Zika, scrub typhus, West Nile, measles, and rubella. West Nile also can present with a rash, and there the clue is going to be a flaccid paralysis. Encephalitis plus flaccid quadriparesis, think about West Nile, and here, we need to send West Nile IgM from serum as well as the CSF. Encephalitis plus extrapyramidal features, need to think about JE, need to think about West Nile, other arboviruses like dengue, and autoimmune encephalitis also. Autoimmune encephalitis also has a propensity for the basal ganglia, and patient can present with all sorts of dyskinesias and autonomic fluctuations, etc. Fever with chills and rigor, periodicity, spinal seizures, and all of you are familiar with. We need to rule out cerebral malaria. Conjunctival congestion, lymphadenopathy are usually not seen in malaria and enteric fevers. Certain clinical features which can help us in zeroing in on the diagnosis. Upper respiratory symptoms are usually absent in dengue, malaria, lepto, and chikungunya. Sensory neural deafness. Sensory neural deafness might give us a clue with regard to encephalitis with strep typhus or in case of neurobrucellosis. Influenza-like illness plus encephalitis plus vasomotor dysautonomia is usually seen in Nipah as well as autoimmune. So basically, vasomotor dysautonomia is something which we observed in around, say, 40% of cases of Nipah encephalitis. Autoimmune encephalitis also, vasomotor dysautonomia is pretty common. And exposure to mammals with brainstem signs, that is, the phobic spasms, could be, say, furious rabies or a paralytic rabies. And rabies is becoming so common that we need to proactively ask for the history of any. And since the incubation period of rabies could be for years together, we need to proactively ask for the history. The GI symptoms plus seizures. So we need to think about the Shigella, which is referred to as Ekeri syndrome. The Shigella encephalitis is known as Ekeri syndrome, especially in pediatric population. Dengue as well as influenza, this can present us with GI symptoms and seizures. So in short, in any patient with meningitis or say meningoencephalitis, we need to take the history properly. We need to assess the immunological status of the patient, and then the epidemiological aspect, the anthropological aspect, the exposure history, clinical examination, give importance to rash, the presence of nose, the scar, and things like that. And based on that, you need to have a pretest probability of what investigation to send, etc. Now, the treatment of meningitis we have discussed. Now, coming to the treatment of encephalitis, the diagnosis should be based on clinical plus epidemiological plus neuroradiology plus the labs. Assess and correct hypoglycemia if present. We need to start on IV as intravenous acyclovir with doxycycline with or without oseltamivir and definitely ceftriaxone because initially we will not be able to differentiate between meningitis and meningoencephalitis. So basically, it will be ceftriaxone plus doxy plus acyclovir, and if influenza-like symptoms are there, till we rule out influenza, oseltamivir could be added. We need to secure the airway and maintain the ABC. The neurocritical care is very, very important part of the management of any the CNS infection, especially in encephalitis and all, where you can go for necrotizing encephalitis and coning, etc., can occur rapidly, especially in the pediatric population because they don't have enough time, enough space in the skull to expand, the brain to expand, etc. So neurocritical care interventions and monitoring of the optic nerve sheath diameter, all these things are important. The role of immunomodulators is actually controversial, but even in encephalitis, if there is evidence of cerebral edema with impending coning, etc., in the immunomodulators like steroids can be tried. Now we will start the patient on doxycycline, acyclovir, as well as ceftriaxone. And if the PCR is coming as negative, can we stop acyclovir? That's the most important thing. So in that context, we need to uh, categorize the patient into those with low probability of HSV encephalitis and those with high probability of HSV encephalitis. So those with low probability of HSV encephalitis will be those with normal neuroimaging, less than 5 cells in this, those without CS or pleocytosis, and those with normal mental status. So in those patients, if you are able to get an HSV PCR negative result within 72 hours of symptom onset, and the chance of the patient having an HSV encephalitis is only 1%. So in those individuals, you can actually safely stop a cyclovir. Whereas in those with high probability HSV encephalitis, like a suggestive neuroimaging finding, pleocytosis, positive EEG findings, or seizures, a negative PCR result reduces the disease likelihood to approximately 5%. In those patients also, if you stop, 95% of the time you're likely to be right, but there is that 5% where, the patient might still be having HSV encephalitis. So in that context, based on all the aspects, it will be better to continue on a cycle. So basically, when we talk about meningitis or meningoencephalitis, the most important thing will be when you decide the investigation to be sent, the pretest probability is the clue. So we need to assess the epidemiological factors, the clinical features, anthropological factors, the immune status of the individuals, host susceptibility, and test characteristics. And based on that, you need to select the right test. And then one word on the brain abscess. So last year, the SMIT came with the brain abscess, the guidelines. So brain abscess also, the most important thing will be that, you need to categorize the patients into immunocompetent as well as immunocompromised. So usually for immunocompetent host, and if they are stable, they don't have evidence of sepsis, etc. So ideally, if you are able to do an aspiration of the brain abscess within 24 hours, or if you are able to exercise the brain abscess within 24 hours, it will be the guidelines suggest that you can actually withhold antibiotics for 24 hours if the patient is stable with no features of sepsis. Okay, that is the key is on trying to aspirate the brain abscess, trying to identify the pathogen. So, and the treatment will be like, the patients who are immunocompetent will be ceftriaxone plus metronidazole. And if patients who are undergone a neurosurgery, there we need to cover for MRSA as well as pseudomonas. There, the empirical treatment will be ceftazidime plus Van Gogh or say meropenem plus Van Gogh sort of thing. Whereas in patients who are immunocompromised, like a post-transplant setting, or a qualitative or a quantitative T cell defect and all, there along with the usual pathogens, the possibilities of a fungal brain abscess, or a endocardiasis or listeriosis also should be considered. There, along with the usual antibiotics, in a case-by-case basis, addition of voriconazole or say cotrimoxazole, etc., has to be considered. So any patient with presenting with a isolated brain abscess, So we need to look at what is a likely source of infection, where it is spread hematogenously from a tooth infection, or and whether the patient is having a CSOM or a neurosurgery or a trauma in the past, or patients with cyanotic heart disease, etc. It's based on that you need to optimize the treatment for a brain abscess. So with this, I think I will stop presentation and will be happy to answer the questions. And one thing I think I forgot to mention was with regard to the use of steroids in bacterial meningitis. So in bacterial
Arvind,
meningitis,
yeah,
yes,
yeah.
sir.
Couple of questions regarding the thing there. So we'll open up
Sure,
the
sure,
questions.
sure.
Sure. So thank you for wonderful presentations. You covered most of the things pertaining to the CNS infections. You touched upon the brain abscess also, and you touched upon common organisms. It's not like Western world. We have seen a lot of other things like influenza, chikungunya, JE. These things is common. So before concluding the sessions, couple of questions has already come up in the chat board. So I'll ask you for your easy references. One of the questions is empirical treatment of meningitis and encephalitis. I think you answered both encephalitis and meningitis. The next question, couple of people are asking serratia meningitis, how to manage?
Serratia meningitis. Okay, so basically in situations like serratia meningitis, like gram-negative meningitis, you need to talk with your microbiologist. You need to look at the susceptibility pattern or optimize the treatment. So I think that will be the way forward with any gram-negative meningitis.
Usually it won't be happen in the community meningitis. It's a nosocomial like BP
Yeah.
or some neurosurgery related things can happen. Usually serratia, the resistance to ceftriaxone is very high. Otherwise, we usually use ceftriaxone. But if you think the person has got serratia, as rightly pointed by Dr. Arvind, check with microbiology. If at all we need to use meropenem, rarely, because cefepime has got tendency to cause seizures. So people little hesitant to use cefepime or ciprofloxacin. So preferred drug sometimes will be meropenem. That's a preferred drug. Regarding the questions, what you want to answer, indications of steroids apart from tuberculosis and meningitis. Now you can answer.
Actually, so the Cochrane reviews have shown that in pneumococcal meningitis, there is a slight mortality benefit with addition of dexamethasone, that is 10 milligrams 6 hourly for 4 days. And this dexamethasone has to be administered along with the antibiotics, or means just prior to the administration of antibiotics, it has to be given. And the data is with regard to the pneumococcal meningitis and H influenza meningitis. And the current WHO guidelines mention that, if you cannot give 6th hourly dexamethasone is not possible, you can use alternatives like hydrocortisone or methylprednisolone. Regarding the duration of steroids, it is actually for 4 days in case of a proven case of pneumococcal meningitis or H influenza. If it is a meningococcal meningitis, you can stop the steroids immediately. And if you don't
Yes.
know the diagnosis, you can stop it at 4 days.
Yeah, I agree with Dr. Aravind. For streptococcal pneumonia, the data is good. For meningococcal, it's not required. H influenza in children, yes, adults has got very dubious data. If you want to use before antibiotic, please start using it there. Then what is the diagnostic criteria for neurocystic cirrhosis they're asking about?
Okay, there's something that means I did not cover neurocystic sarcosis. So basically, you need to have a neuroradiological diagnostic criteria set by WHO is there in 2021 the guidelines, I believe. So I think it's a bit complicated to describe in detail here.
Yes. Yeah.
So
Lot
I
of
will
other
request
things
all
are
of
there.
you to go back to WHO guidelines and 2021 guidelines on neurocystic sarcosis based on the stage they have put it. For the stage like that.
Yeah, usually absolute criteria, major criteria, some Delbritos criteria also commonly we are using it. One is histological demonstration, that is a definite or absolute thing there. Similarly, the MRI finding of cystic circus with the Scolex that is demonstrating that is almost equal to proving it. If it is a retinal involvement, subretinal involvement, if you are able to see the larva, that's also fine. Then major criteria, usually the MRI imaging is suggestive of the lesions along with some Scolex manifestations. And nowadays we are doing the antibody test also there, so that we can use it. And response to the treatment of spontaneous resolutions. These are all the common criteria we are using it. The other question is coming up, can NTM can cause encephalitis?
NTM actually, in select cases, NTM can also lead to encephalitis or meningoencephalitis. But the thing is that we need to prove it, and the treatment is going to be very much complicated. So basically, in situations we need to have a very good rapport with the microbiologist. The species had to be identified, and susceptibility pattern has to be identified, and sort of things like that.
Yeah, Arvind has touched upon it there. Suppose the host is most important. Immunocompromise, for example, HIV, BC, Mycobacterium, avium complex, disseminated can happen. Similarly, for the VP shunt or something, there Mycobacterium abscesses, if the shunt is contaminated, is possible. Usually, in immunocompetent community acquired chances are a bit low. Immunocompromise, he clearly touched upon immunocompromise. Our differential diagnosis should be broad there. Similarly, people are asking about coronary bacterium diphtheria got any CNS infections.
Diphtheria, CNS infection, meningitis, meningoencephalitis.
Yeah, agree with him. There's no direct invasions of coronary bacteria, but the toxin can produce some polyradiculopathy or neuropathies can happen there, but not in the brain involvement. Is not going to happen. And people are asking about when to repeat LP for a bacterial meningitis.
Actually, in the usually what we do is that the patient is improving, we don't think about repeating the CSF study. If the response to treatment is not optimal, it is in such situations that we can think about repeating the CSF study. And the current WHO guidelines, they mention that even after 7 days of treatment, the patient is not improving. This at that time you can have a reassessment of the patient and you can have a repeat CSF study and plan other investigations. But for all practical purposes, if you don't know the etiology and if you have a doubt between a partially treated pyogenic meningitis and a tuberculous meningitis, etc., so, and you are starting the patient on empirical antibiotics and repeating the CSF study after, say, 72 hours or so, and we are expecting the sugars to improve, the hypoglycemia to normalize in case of a bacterial meningitis. And if that is not happening, probably, the patient with, meningitis, hypoglycemia, and our DDs are going to be a pyogenic meningitis, tuberculous meningitis, fungal meningitis, neoplastic meningitis, or an amoebic meningitis. Of which the most common will be a pyogenic meningitis and a tuberculous meningitis in case of a subacute or two chronic sort of presentation. There, repeating a CSF and looking for optimization or normalization of the CSF sugars in patients on antibiotics will help you. So basically, those decisions are based on a case-to-case basis.
I agree with Dr. Arvind. Mostly in adult populations, we don't repeat the CSF. Pediatricians, they want to check the clearance of the bacteria or clearance of the count has come down. But adult populations, unless the clinician not sent for most of the things, or unless he preserves the sample and the diagnosis is still elusive, the patient is not improving, we don't repeat. And the diagnosis is made clinically better, nobody want to repeat to check whether clearance happened, but pediatricians still love to do it. Adult populations is very difficult. But if you're not done sufficient tests or you don't have samples first prime and the patient is not clinically improving, yes, we can do. One more question is asking, the person has got raised ICP. It's not possible to see, sir. What should we do in that case, sir?
The patient is having a raised ICP. There are two options here. Basically, we need to have a discussion with the neuroradiologist to see whether using a finer needle, a CSF can be obtained. So that is one aspect. If you are, that we will consider only if the patient is not responding to our empirical treatment. So based on the clinical picture, the other investigation, etc., we need to have an idea about what is the likely pathogen and start empirical treatment. And if the patient is not improving and if you're still in doubt regarding it could be some other pathogen, we can have a assessment of with the discussion with the neuroradiologist and using a finer gauge needle, etc. You can plan a CSF study. So that has to be decided case to case basis. So,
yeah, similar thing like people are asking about papilledema is present. I can't do CSF. What to do there?
actually, the current guidelines are more focusing on when not to do the imaging. Like so, within say 1 hour, the antibiotic has to be in the case of bacterial meningitis. And our usual practice is that for all cases of suspected meningitis, we will send for a CT brain and we will lose 2 hours with that. And then we will send the blood culture and CSF culture, and the antibiotics might means we may not be giving within 1 hour. That aspect is actually covered in all the guidelines. They clearly say that what are the indications where you should go for a CT imaging. But here the question is that there is a papilledema and you are not able to do a CSF study. So there basically the distance have to be you have to start the patient on empirical antibiotics. And you can send a blood culture in meningitis, etc. The blood culture yield may be pretty good. And then if there is no response, you can think about discussing with the neuroradiologist and do a CSF with a needle sort of thing.
Agree there. So in consultations with the neuroradiologist, Sometimes using a small bore needles, we can try CSF at the guarded prognosis if really indicated. Otherwise, mostly we do blood cultures and radiological imaging. One more question, Dr. Arvind, regarding 16S RNA PCR. When will you going to do that? When the person has got negative biofire also, negative cultures also, yeah. What is the role of 16S RNA?
Actually, this can be tried. So, the shotgun metagenomic sequencing, targeted sequencing, all these things have been tried. For example, if you're looking at the literature on encephalitis prior to, say, 2020, the yield anywhere in the world was, say, 25 to 30% of the encephalitis had diagnosis, 70% no diagnosis. But if you're looking at the current data from the Western world, around, say, 50 to 60% they are having diagnosis because they have adopted this sequencing methods also into the diagnostic armamentarium. But regarding this, WHO is very clear. So when you are interpreting the multiplex PCR data or sequencing data, keep in mind the clinical presentation as well as the other aspects. You need to have an idea about what you are expecting. So otherwise, you cannot make sense out of all these molecular as well as the sequencing methods.
Yeah, agree. One more thing they're asking about miliard, they're seeing a lot of in Pondicherry. So what is the test there for neuromiliard they're asking for it?
Neuromiliodosis, actually, almost all the tests are available in India now. So what we rely upon is actually the culture methods, but Manipal and CMC, etc., can do the PCR as well. And they have an ELISA also. Basically, we need to keep a very high index of suspicion for neuromiliodosis. Otherwise, we are likely to miss. Suppose we are lucky enough that there are evidence of a pyogenic focus elsewhere, we'll think about neuromiliodosis. But if the patient is presenting without a pyogenic focus elsewhere, just as neuromiliodosis, we might miss the diagnosis. And recently, in a nearby hospital, patient was misdiagnosed as autoimmune encephalitis and was started on steroids, and later the CSF culture came as Burkholderia pseudomyeli. So basically, the index of suspicion has to be pretty high. We're lucky that Manipal, etc., can do these are the ICMR sites, they can do the PCR as well.
So a lot of centers is coming up, and even blood cultures usually pick because this is a disseminated one that from blood it's going on. So we can able to pick in the blood culture itself, and CSF we can ask them to put it in the blood culture bottle also, so the yield can come up. And as he rightly told, a lot of national centers has come up. One more question is regarding autoimmune encephalitis. Can steroids be tried empirically when we think autoimmune encephalitis?
This is a very tricky question. So one thing we need to keep in mind is that over the last 10 years, a majority of the centers have got access to diagnostics for all these antibodies. Okay. And then we have seen a surge in autoimmune encephalitis in the country. So basically, it is getting picked up. That is what we understand. And then can you start empirically on steroids? Depends on whether you have ruled out all the infectious etiology, etc. So diagnostic clues will be like a patient is acting weird, talking weird, and MRI is normal, and dyskinesia says they are autoimmune instability, etc. You need to think about an autoimmune encephalitis. Talk with the neurologist because now they have access to all the panels, the serum panels as well as the CSF panels. And I believe that in conjunction with the neurologist, based on the panels, etc., we need to try steroids.
And a couple of questions is put in the chat box, even though it's not related to the infectious diseases. For example, when the person is highly irritable, what to start? CSF rhinorrhea. Since we're really running short of time, I asked Dr. Arvind to respond in the chat. Meantime, we'll ask the posters questions and wind up the session there because we are already 8:30 now. So I'll ask Dr. Arvind to respond in the chat. People are asking when the person is irritable, what to do, and CSF rhinorrhea. A couple more things we left out there. Most of the questions I asked for you. Meantime, we'll run the posters questions for the audience there. Yeah. Thank you. Dr. Arvind, you can start answering the chat bot. I'll start the posters.
Sure, sir. Sure.
So this is a 42-year-old male from suburban part of Tamil Nadu, farmer by occupations, 10 days of fever. He got body pain and headache, cough, minimal expectations, and shortness of breath. On examination, the person is confused. The pulse rate is tachycardic. The person has got hypotensive. Neck stiffness is present. So this patient has got CNS infections. People are answering always every time they put their name and ask the attendance. But attendance is always an infectious disease short course depends upon the answers posted to the questions. So please start answering so that you can get the attendance rather than putting your name, you don't get attendance. Other sessions, yes, you usually always put your name and get the attendance. But here you need to answer and get the attendance here. Okay. I'm seeing how many people are answering now. 84 are there still. Okay. 10 people are answered. 11 is answered. Good. People say this is CNS infections. Good. So Clearly, Dr. Harvind told, person has got fever, headache, neck stiffness, or meningismus is a sign the person has got meningitis, but it's very difficult to differentiate. So whenever you encounter a patient with fever, headache, neck stiffness, or meningismus, we can call it, the chances of CNS infection is very high. If the symptoms are not there, the chances are ruling out. So this is more important. So this is one of the beautiful paper called JAMA. Whenever we encounter these questions, we need to ask, does this patient has got CNS infections? Or does this patient has got meningitis or encephalitis? Usually presence of combinations of the symptoms and signs, the infection rate is very high, but negative predictive value is very good. But CNS is one conditions where very difficult to predict what is going on, very difficult to predict. That is why this is called a real emergency. This is one of the real medical emergency. We can't treat like another thing. So if you think the person has got meningitis, take appropriate samples for stunting cultures, start antibiotics. Don't wait. If you wait, the person will not be alive tomorrow. That's most important thing. So, but before that, make a diagnosis. That's most important thing. We can't expect this one everywhere. The first loaded with the brain, it is not going to happen everywhere. And this is one of the beautiful infographic created by WHO. What are all the red flag signs when we encounter a meningitis and meningoencephalitis? We need to see, particularly conditions like petechiae, purpuric rash, rapidly progressing. Always think not only to the patients, but also you are exposing to the meningococcemia. Clearly, Dr. Arvind talked about the Nipah viruses. These are all things can cause to the healthcare workers. So some of the other viruses like JE, these things always keep in mind. When encountering meningitis, meningoencephalitis, your safety is also very important. Think about it. That is very important. These are all the 4 common CNS infections: meningitis, encephalitis, meningoencephalitis, abscesses, and all these things carried touched by Dr. Arvind in his presentations extensively. And this is a chart we need to keep in your bedside or you keep in your clinic also, how to differentiate bacterial, viral, TB, and fungal infections. This is common thing we always need to keep in mind. Always measure the opening pressure. That is also going to help out. See the color of the CF, that is more important. Measure the corresponding blood sugar. Whenever you do the CSF, corresponding blood sugar also you need to measure it. That's more important. And imaging is more important in encephalitis, except TB. TB, we can able to make some meningitis changes, basal enhancements we can able to see. But depending upon the location, Dr. Arvind clearly told what are all the viruses, we need to think about it. What are all the viruses? But encephalitis, yes, imaging is one of the most important thing, particularly MRI has got more value compared to bacterial process of it. So that's most important. This is a simple thing I can put it. Temporal lobe means what do you think? The person involved the brainstem, what I need to think. The person has got vasculopathy or the person has got spinal cord involvement, what I need to think. This is a simple. These algorithms are coming shortly in our CME next week there. And most important, when you start using, one of the comment made by one of the participants saying that Serratia cefepime is a drug of choice. Yes, cefepime is a drug of choice, but we need to think about the toxicity. The commonest side effect of cefepime is encephalopathy there. So that's why when a clinician want to use some drug, we need to think about the side effects, but we need to think about the penetrations to the brain. That is most important. Ampicillin has got good penetration to the brain. Amoxicillin is not a penetration. So that's why Listeria we see ampicillin compared to the ceftriaxone and cefotaxime. In a newborn, cefotaxime is preferred compared to the ceftriaxone. So think about it, which is going to penetrate the brain, and we usually use to double the dose. For example, Serratius, instead of meropenem 1 gram, we use 2 grams TDS. That's one of the questions people are asking there. And this is the latest guidelines available. So we usually provide a lot of latest literatures also. So you can read about it. Clearly, the durations of meningitis and meningoencephalitis treatment is also coming down. For example, meningitis, he really pointed out, Neisseria, we can treat 5 to 7 days. For Haemophilus influenza, 7 days is more than sufficient. Strep pneumonia, 10 to 14 days. And similarly, certain organisms like Listeria, we need to treat longer. Milioid brucellosis, we treat longer, and combination therapy. This is just published in 2025. Always update these guidelines for you. The duration is coming down. That's most important. The case turned to be encephalopathy. Even though the person has got fever, some terminal neck stiffness, confusions. So encephalopathy and encephalitis is always confusing. He's shown a cases of scrub typhus causing meningitis. But here the scrub typhus is caused encephalopathy, not encephalitis. The scrub typhus affected the skin and other organs, but not the brain. The brain reacted to the scrub typhus. This is called the scrub typhus case. And these are all the algorithms we are working on it. Next week, the algorithm, mastering and IT algorithm CME, we are going to show how to approach, what are the methodical ways we are going to evaluate. This is a premier for the thing. The next week, the CME is coming up. This is a CME we are coming up. So please keep in mind, those who are not registered, please register for this one. Thank you. So I think most of the questions is answered today's sessions. I sincerely thank the AP and ICP for giving this wonderful opportunity. I thank Dr. Haravind for spending his valuable time and doing an exhaustive presentation. Some of the comments saying this amazing presentation, Dr. Haravind. It's a lot of presentations, and usually we share the content. Whatever content you want to share with the participants, please share the content so that we can put it in the group. We got a group for the short certificate course. We can put it in the group. And if possible, you can create some questions also to test the knowledge of the participants, because exams can happen towards the end of almost 22 weeks this course is going on. Right now, 9-10 weeks is over. Another 10 to 12 weeks, exams can happen. So can you send your questions also? We can keep in the question paper. That's also thank you. And most of the things is answered. Last 1 minute, even though we overshooted almost 8 minutes. Any last minute for any burning questions for asking the faculty here? Still 70 people are online there. If no questions, thank you again, the organizers as well as the IT team supporting it, and the speaker as well as the participants who joined. Thank you once again. Next week we'll meet. And next week, probably like the CME is overlapping. I just coordinate with the central faculty and get back to you who is the speaker, or can postpone to next week or something. I'll let you know shortly there. Till the time, thank you once again. Thank you, Dr. Arvind.
Thanks.